Hello everyone. Today I'll be covering the part of the seminar for ECG Test 2. What I'll be covering exactly is an overview of the 10-step ECG analysis, and then I'll go into depth, well, what is required at least for the action, rhythm, frequency, and P-wave analysis. For the other parts, my colleagues will record their respective parts and it will be shared with you. So just a brief overview of the 10-step ECG analysis. You're sort of already aware of what the 10 steps are that pathophysiology expects you to know. One important thing to note is that if there's any abnormal findings, by that it means that any finding that is outside of the normal range, it should be marked somehow, let's say with an exclamation mark or underline or just circle it. But most commonly, you can just, most commonly what people do is just underline it. So yeah. So about the action, so it can be either regular or it can be irregular. And the most common way to check this is the paper method. And unfortunately, I can't show you now because I am not recording myself. But essentially what you do is you draw a line on the paper, and then like on a different piece of paper, not on the ECG tracing. You draw a line at one RR interval, an R peak, and then you draw a second line at the second R peak, and then you just slide this paper across the ECG tracing. And if the RR intervals or the lines, they sort of seem like constant, in that case, it is regular. By constant, I mean that the difference between them is less than 0.16 seconds, which is basically 4 small boxes in the horizontal direction. It can be irregular when the R intervals are not constant. Some physiological conditions in which this can occur include respiratory arrhythmia. Pathological conditions include arrhythmias, extrasystole, or AV blocks. It is important to note that for extrasystole, if you just see one, it's still a normal rhythm, but you must mention along with your normal rhythm, that one extrasystole was seen in this ECG tracing. We'll see an ECG example of this later on. A bit more about the action. So if it's atrial fibrillation or flutter, what you have to mention is first and foremost the waves. It is capital F waves for flutter and small f waves for fibrillation. If regarding the rate or the frequency of these waves, for flutter it's 220 to 360, but generally up to 400, you can just denote it as flutter. As for fibrillation, it is between 400 and 600. Anything around the 1000 to 1500 mark is most probably not due to any electrical activity of the heart, but rather, let's say, some electrical excitation of the skeletal muscles, let's say, because even pathologically, the heart cannot conduct or beat that fast. And regarding the atrial fibrillation or flutter, in case they are present on the ECG tracing, you must also mention the corresponding ventricular response. So whether it is normal or whether it is rapid. And this mainly depends on the heart rate. So you might see atrial fibrillation, but what really determines the ventricular response is the heart rate that's calculated, which we'll get to in a bit. Regarding extrasystole, it's basically, how do I say this, an interference in the normal ECG tracing, and it's usually followed by a compensatory pause. For extrasystoles, what you have to do is you have to note first and foremost the origin, whether the extrasystole is of ventricular origin or if it's of supraventricular origin. The ventricular ones, they usually look bizarre in the sense that the QRS is prolonged. It just looks like an abnormal beat that's very clearly visible in the ECG tracing. As for supraventricular, it just looks like a normal interference within the QRS complex. Whether the supraventricular extrasystole is atrial or junctional, they don't really expect you to know, just mention it's supraventricular. As for the location of the extrasystoles, you have to mention whether it's monotopic or polytopic. So if the if the extrasystole are of monomorphic, like the morphology is identical, then they're most probably monotopic. But most commonly, it is polytopic in the sense that they are from different origins. The QRS complexes look different. And then the extrasystole can also be regular or irregular. The regular examples include bigemania, trigemania, and quadrigemania, which basically means 1:1 ratio between a normal beat and an extrasystole. So it goes like 1 normal beat, 1 extrasystole, 1 normal beat, 1 extrasystole, and so on. Trigemania is a 2:1 ratio, and quadrigemania is a 3:1 ratio. The higher numbers, or the greater numbers, basically being the normal beats. And in most cases, it's irregular actually. It's not like bigemania, trigemania, or quadrigemania, but you must know of its existence. Next up, we have the rhythm. So the normal rhythm is actually sinus, and the way you determine this is looking for positive P waves in leads 1 and 2. But what I think is most important is that a P wave should be in front of each QRS complex. A non a non-sinus rhythm are the irregular rhythms, and examples of this include atrial or junctional. For junctional, the characteristic thing is the missing P wave. There can also be ventricular rhythm, and in this case, the QRS is prolonged. It's not normal, and the P wave might be missing. And the ventricular rhythm, what they expect you to know is that it can be seen in a third degree AV block. To explain why it might be seen, it's because in a third degree AV block, nothing from the sinus node is being conducted to the ventricles. So essentially, the sinus node is having its own electrical activity, and the ventricles are having their own electrical activity. So on the Q or not on the in the on the ECG tracing, what you'll essentially see is P waves and the QRS complexes. They are independent of each other, like they're just happening on their own accord. There's no connection between them, which is abnormal, obviously. We'll get to an example in a bit. And then another example of irregular rhythm could be atrial fibrillation or flutter. Regarding the frequency, there's a formula that's provided in your script. I don't really remember what the formula is, and I don't think it's too important either, because the most common way to determine the heart rate is multiplying the number of QRS complexes with 6. So let's say you have 10 QRS complexes that you count on the ECG tracing. If you multiply that by 6, that's 60, and well, they will accept that as the heart rate. The normal is between 60 to 90. You might see other ranges that might be provided, such as 50 to 90, or even 50 to 100 in some cases, but universally you can sort of accept this as the normal heart rate. Anything less than that is bradycardia, and anything greater than that is tachycardia. So I have some examples now, and like what I want you to primarily try and determine is the action, the rhythm, and the heart rate. And then if you want, you can pause for longer and try and determine what the diagnosis would be. So regarding the first one, it's actually a regular action because the R intervals are constant. And the rhythm is sinus because you can see that there is a P wave before every single QRS complex. Especially, this is very well seen in lead 1 itself. And their heart rate is 52 beats per minute. The diagnosis in this case is sinus bradycardia, well, because the heart rate is less than 60. And I believe there might be some sort of left ventricular hypertrophy as well, if I'm not mistaken. This is the second ECG. And for this one, the action is actually irregular. And if you take a look at the entire ECG on, like, let's say, a more broader view, not like focusing into each individual lead, you can see that the reason why it's irregular is because there are 3 exosystoles. So it's irregular. The rhythm is, however, sinus because each normal QRS complex, I don't mean the exosystoles, but normal QRS complexes are preceded by a P wave, and the heart rate in this case is 96 beats per minute. So there is some sort of tachycardia. So the diagnosis in this case is sinus tachycardia with extrasystole. Now, as mentioned before, there are certain things you have to know or you have to comment on when there's an extrasystole. First and foremost, they are of ventricular origin because, well, they look bizarre when you compare them to the other QRS complexes. And you must also comment on whether it's regular or irregular. And in this case, obviously, it's irregular, don't seem to occur in any sort of pattern. And finally, whether it is monotopic or polytopic. So this is very well seen in lead view 1 that 2 of the extrasystoles they'll appear sort of similar, but the third one is completely different from the other 2. So yeah, in this case, it's a polytopic ventricular extrasystole. This is the third ECG. For this one, the action is regular, but one thing, if you paid attention, like if you paused and actually like tried it out yourself, you would realize that there is an extrasystole somewhere, and particularly 1, 2, 3, 4, 5, 6, 7, 8. The ninth QRS complex is actually an extrasystole. And the way you would find this out is if you checked for example, the lead AVF before you can say it out in your mind like PQRST, PQRST, PQRST. And when you get to the eighth QRS complex, you'll see that there's a PQRST, but then there's suddenly another beat without any P wave, and then it's followed by T wave, and then like a long pause. So this is basically an extrasystole. It's an interference in the normal ECG tracing. And in this case, it would be supraventricular because it appears very similar to the other QRS complexes, all right? And getting back to the other descriptions, it's a sinus rhythm because in AVF you can clearly see the P waves, and the beats per minute is 72. The diagnosis in this case is supraventricular excess systole, one of them, and there's also an acute myocardial infarction in the anterior-septal location, because you can see that there's significant ST elevations in leads V2, V3, and V4. And this is with corresponding ST depressions in leads 2 and AVF. Then we have ECG tracing 4. In this case, the action is regular, and the rhythm in this case is actually non-sinus. This one is the example of the third degree AV block that I talked about before. As you can see, like the P waves and the QRS complexes are happening completely independently of each other. In some cases, you might have two P waves between each QRS complex, or you might even have, well, a P wave just next to a QRS complex. It doesn't follow any sort of trend. So yeah, this is a third degree AV block with idioventricular rhythm instead. Regarding its heart rate, it's 32, so there's some sort of bradycardia as well. So moving on to P wave, the two things that you're expected to do for P wave are calculation of the P wave amplitude and then the durations, particularly in leads 1 to 3. For each lead, you're expected to state the amplitude, but you only state the longest duration overall. And the normal values are provided here. In my opinion, the best lead to check is lead V1 or the leads around it. So this would be lead AVF or lead V2, let's say. The pathologies involving P wave are prolonged or when amplitude is greater than the normal value. In that case, that's P pulmonale, and the previous one was P mitrale. Or it can even be atrial flutter or fibrillation. Just some comments on these in particular. For P mitrale, when it's prolonged, usually the P wave takes on what you call a double peaked appearance. And in my opinion, the way I remember it is that the double peaked P looks like an M, so M for mitrale. And obviously, if the prolonged is mitrale, then the one that's taller is pulmonale. There's no question about that. It's either or. And for atrial flutter, you know that there is like a particular rate at which the F waves, capital F waves occur. But there's a characteristic morphology of sawtooth appearance. For atrial fibrillation, there's no such characteristic appearance, but the only way to really get a diagnosis is through experience and while calculating the frequency in between these oscillations. There's an important thing to just like really how do I say this? Like hammer it or nail it into your heads is that if in case there's an atrial fibrillation or flutter, you do not do anything for the P wave, so you do not determine neither its amplitude nor its duration. You just leave it alone. In fact, you can even get penalized if you do anything for the P waves. So just some examples. In this case, particularly in leads 1 and 2, you can, well, not to 1 and 2, sorry, 2 and 3. It's also sometimes difficult to sort of distinguish which one is the P wave and which one is the QRS complex. For that, I would recommend you look at leads V1 to V6, and you can see clearly which is the QRS complex. So if you compare that to what is above, you can see that in fact the P wave's amplitude is greater than the QRS complex itself. So this is without a doubt P pulmonale. In this case, particularly if you take a look at leads 2 and the lead AVF, you can see that the P wave, it sort of takes on like how do I say this? Like a double peaked appearance of M. For example, you can see this in the third P wave of AVF, or you can see it as where is another place where it's very well visible. Hmm. Well, I believe that is the best one that I can see. Perhaps you can see something better, but yeah. So there's a prolonged P wave, and it looks like M, so P mitrale. This is the characteristic sawtooth appearance of atrial flutter that's very well seen in leads AVF and V1. Um, yeah, and in this case, what you have to mention is obviously the the F the frequency of atrial flutter waves, the capital F waves, and you also have to mention the ventricular response. So in this case, if you calculate the heart rate, it's 52, so it's with normal ventricular response. Hmm. And this is atrial fibrillation, which is particularly seen, like it's seen pretty well in leads AVF and V2 in my opinion. And honestly, there's no characteristic way to like recognize it. But if you realize the heart rate is irregular and or yeah, the heart rate is essentially irregular, like there's no, the action in this case is irregular. And if you calculate the frequency in between the small F waves, it's around 400 to 450. In this case, the how do I say this? The ventricular response, since the heart rate is 96 beats per minute, there is rapid ventricular response. So that is pretty much all I have for you today. I wish you the best of luck for your ECG test. And yeah, that is all.
So today we're going to be talking about mainly the PQ interval and the Q wave, and I'll just be going over some points to note for your ECG credit. So it's not an exhaustive presentation, but just like the most important stuff that you should keep in mind for your test. So starting off with the PQ interval, as the name suggests, it starts from where the P wave is beginning, and then it goes up till the beginning of the Q wave. And you can measure it in the most distinct lead available, and it usually is in V1, but then it could be annihilated. It depends on your opinion. And what does it represent? So it's telling you how much time it takes for an impulse to travel from the SA node where it's generated to all the way up to like the bundle of his Purkinje fibers, etc. And that's basically it's like uh, a visual representation of that duration. And normally this should be between 0.12 to 0.20 seconds. And on our ECGs, which are, I believe, 25 millimeters per second paper speed, that would be around 3 to 5 small boxes long. And as for pathology, this is a normal, but in pathologies, what can happen is that it can be prolonged or shortened. And both of these are obviously pathologies. A prolongation means that something is blocking this impulse from reaching its location on time. So these are called AV blocks, and we have 3 different degrees of this, which I'll cover in the coming slides. And if it's shortened, where it's lesser than 0.12 seconds, then it means that the impulse is somehow reaching earlier for some reason. And the only pathology you need to know here, I guess, is the syndrome of pre-excitation, the Wolff-Parkinson-White syndrome. Okay, so over here, these are just a few examples before I get into the details of it. So as you can see, this over here is normal AV conduction, where the PQ interval happens to be between 0.12 to 0.20 seconds. Over here, you see a prolonged PR interval or the PQ interval. Both of them mean the same thing. And it is greater than 0.20 seconds. And here the cause indicated is an AV block of first degree. And here you see the pre-excitation syndrome, like I mentioned earlier. So basically what happens in this is that you have, in addition to your existing normal pathway, you have an accessory pathway that's bypassing the AV node. So because of that, you have some impulse that manages to reach the rest of the fibers earlier, and because of that, you get this uh, abnormal appearance with the QRS complex, and it's called a delta wave. But it's not very important. It's unlikely that this would show up on the test, but the AV blocks, they are important to note. Okay, so let's have a look at what first degree AV block is. So using the word block isn't really right here because it's more of a delay in impulse transmission. I won't go into the pathology, but just to understand that, like I'd mentioned earlier, how the impulse is going from SA node to AV node, and like ahead. So over here, there's something that is basically delaying that transmission. It could be because of a number of diseases. So as a result of that, you get PQ prolongation, which is a pretty like understandable natural consequence. So how does this look on the ECGs? You'll have the same number of P and QRS complexes. So that means that there are no beats dropped or anything like that that we see in the coming AV blocks. And the PQ interval is prolonged, of course, and it is also constant. That is important to note. So if you see over here, this PQ interval happens to be around 0.34 seconds, like it's indicated, and it is before every QRS complex, even though there's only two over here, but take my word for it. And it is constant as well, it's not being altered. So these are the characteristics of a first degree AV block. Now let's talk about the second degree AV block. So we have two types over here, type 1 and type 2. First, I'll talk about type 1, which is also called Mobitz type 1 or the Wenckebach type of AV block. And over here, what happens is you have some sort of impairment that's resulting in a failure to conduct impulse. And this block is around the point of the AV node. And as a result of this, since you have a failure to conduct impulse, the number of P waves is not equal to the number of QRS. So uh, that if you look over here, you see like, okay, P wave, P wave, P wave, P wave, and no QRS complex. So that's what they mean by number of P is not equal to number of QRS complexes. And the PQ interval is not constant either. It increases in a successive manner until one impulse isn't conducted at all. So if you have a look over here, a normalish looking PQ, P wave followed by QRS, PQ interval is now prolonged, PQ interval is even more prolonged, and then finally a P wave but no QRS seen. So that is a dropped beat. And then it starts up again after that and continues similar to this. So those are the features of this, and this rarely progresses to a third degree block. So it's not as serious as having a type 2 AV block of the second degree. Okay, now let's have a look at the Mobitz type 2 block. And this happens because of some sort of block that's below the AV node. How does it manifest? So the number of P waves is not equal to the number of QRS complexes, similar to type 1. However, over here, instead of the PQ interval increasing in a successive manner, it is constant. And there will be like a sudden failure to conduct a signal resulting in a skipped. So what that means over here, if you have a look, the PQ interval is prolonged, P and QRS present, similar PQ interval, P wave, but no QRS complex. So that's like a random skipped beat. Then it starts up again, normal, not normal looking, I mean prolonged, but you have P, QRS, T, P, QRS, P wave, and no QRS complex. And this might occur in a ratio, like a 2:1 ratio or 3:1. So over here, you have two waves conducted and one not. So you would have to indicate this in your report when you're writing it during the credit. And clinically, this is more dangerous since it's more likely to progress to a third degree AV block. Coming to the AV block of third degree, over here, no atrial impulse makes it to the ventricles at all. And there is complete AV dissociation. So they're beating in their own rhythms that are disconnected from each other. The site of block may be at the AV node or lower, and the number of P waves is distinctly more than the number of Q waves, since the ventricles, what they do is they're not receiving any impulses from the atria. They respond by generating an escape rhythm, and this happens to be way slower than the atrial impulse. If they originate above the bifurcation of the bundle of His, it would be between 35 to 50 beats per minute. And if it's below the bifurcation of the bundle of His, then it's between 20 to 40 beats per minute. So if you have a look over here, you see a P wave, P wave, P wave, P wave, P wave, and then P wave, P wave. Like basically they're running along their own thing. But then the QRS complexes uh, seem to be having a rhythm of their own. So points to note over here, firstly, you will see that the number of P is greater than the number of Q, but the RR interval is the same. I'll have a mind map on the next slide, which will help you like uh, basically come to a decision about what is what. And also you see that the rhythm is quite slow, because let's count the boxes here. It's like around 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11-ish. So when you divide like 300 by that, like that's a quick way to get to the heart rate. And then let's say it's around like 30 beats per minute or something. And that basically indicates that this, you have a very slow rhythm, you have a regular RR interval, but you have random P waves that have no relation to it. So that basically points you to a third-degree AV block. Mind map that they shown us in class, and you can draw this during your test as well, like on the side, just to like help you in case you get confused. So first thing you do is you check if the number of P is equal to the number of QRS. If yes, then you can have a look at the PQ intervals now. And if it's between 0.12 to 0.20, then you know it's normal and there is no blocks of any sort. If it is shorter than 0.12, then it's probably like syndrome of pre-excitation. Then if it happens to be more than 0.20, but like PQ interval is like constant and number of equal QRs, then you know that there is a first degree AV block, where like I mentioned that there is no skip beats, but it just is prolonged. That's it. That's the only anomaly. Now coming to the others, which might be a bit harder to differentiate. So for every other type, like the second degree and third degree, you do not have number of P equal to number of QRS. And then after that, let's see if there's a constant PQ interval. If it is not constant, then you can check if there's a constant RR interval. And if the RR interval is not constant, then it's most likely a second degree AV block type 1, because let's recall what happens in type 1. The PQ interval seems to increase in a successive manner until eventually a beat is dropped. So keeping those factors in mind, successive increase, so a non-constant PQ plus number of P not equal to number of QRS, you can come to the conclusion that it's type 1. Whereas if you have a constant RR interval, but then random P waves which have no relation to the QRS complexes, and number of P is way greater than number of QRS complexes, then you know that it's a third degree AV block. And then now if you have a constant PQ interval, but number of P is not equal to number of QRS, then you know that it's second degree AV block type 2, where like we already discussed, the PQ interval is constant until one beat gets randomly dropped. So, I mean, it's not very hard. You could remember it yourself, but if you seem to have trouble differentiating them or something, it's a good idea to draw this on the side. It can just help you out. Okay, so now this is like a small test. You can pause the video here and test yourself, and then I'll discuss the answers on the next slide. Okay, so this one over here, we see that the P waves are running independently of the QRS complexes. It's very evident. We see that the RR interval is constant. And what does that tell us? naturally you come to the conclusion that it's a third degree AV block. And I think it's pretty obvious from the P wave just randomly appearing everywhere, and the fact that we have a constant RR interval. Well, let's have a look at the second one. Over here we see a PQ interval that is prolonged. I think you can measure it better over here. It's about 1, 2, 3, 4, 5, 6, almost 7-ish small boxes. And we discussed earlier how it has to be around like 3 to 5 small boxes long. So this is definitely a prolonged PQ interval. Now, is there one before every QRS complex? It looks like there is PQRS, 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 PQRS. Be sure to check the entire strip so that you're not missing something or whatever, because it in ECGs like this, like it's easy to miss it because everything just looks like it's all smushed together. But since that's the only pathology we're seeing, a prolonged PQ interval, we can say that this is an AV block of the first degree. And then in this one, we see a PQ interval that is prolonged for sure, because this is around 1, 2, 3, 4, 5. This one seems on the edge. Then let's have a look at the next one. This is definitely way longer than the last one. It's about like almost, I'd say, like 10 small boxes or something. And then here we see a P wave and there is no QRS complex. So we see a PQ interval that is successively increasing. We see that the QRS complex is dropped. And then that's going to point us to the fact that it is an AV block of the second degree, but of the first type. Briefly discuss Q waves. So what they normally represent is a left to right depolarization of the interventricular septum. And the normal duration is less than 0.02 seconds, so that's like half a small box. But please be aware that it's normal to have a prolonged Q in lead AVR. If it's around 0.03, it's suspicious, and if it's 0.04, then it's indicative of a scar after an MI. So the context you'd be seeing this in your ECGs is mostly an MI. Either it could be a subacute one, or it could be a chronic MI if that's the only change that is present and like all the other QRS complex findings are normal. So if you see how the ECG findings progress in an MI is when it's hyperacute, you'll see the Pardy's wave and elevation, and there is no there's no Q wave over here when this is just within minutes. Then within minutes to hours, you see that this is the Pardy's wave appearance, where it's sort of like parallel-ish to the isoelectric line. Then as we progress to the first hour, a Q wave starts to appear, and the elevations are not as elevated as they were earlier. And we might even start to see T wave inversions. Then when it's chronic, around days to weeks, we see a Q wave and T wave inversions. And then finally, after it's been like months to years, you might just see a Q wave. Wave appears is that the necrotic tissue, it does not have any action potential. So during the ECG, the infarcted area, like instead of the action potential being picked up from there, it ends up being picked up from the opposite side of the heart where the impulses are traveling the other way. And because of that, you get this um, Q wave that's like having basically like negative amplitude because of it being picked up from there. You don't really have to know this, but it helps to like understand why this Q wave is appearing. Now, if you find a Q wave, it's important to indicate in what area it has occurred and whether it happens to be an acute, subacute, or a chronic MI. And you will be able to tell this on the basis of like other findings like ST elevation or T wave inversion and stuff like that. So leads 2, 3 AVF are inferior, lead 1 AVL and V5, V6 are lateral. Anterior is V3, V4, and septal is V1, V2. If you happen to see like V1 to V4, then you can say it's like anteroseptal. And yeah, so it's important to remember this, do memorize it, and be sure to mention it because they do expect that from us during the credit. So over here, once again, you can pause it and test yourself, and then I'll discuss the answers on the next slide. So let's look at the first one. We see over here no Q wave really, but over here we see something in lead 2. We see that it's present in lead 3 as well. And then AVR it's normal, so we ignore it. Nothing in AVL, but we also see a Q wave present in AVF. So what else is present here? We see ST elevations. So we can say that since this is affecting 2, 3, and AVF, it is an inferior myocardial infarction. And you can say it's about acute since we see ST elevations along with it as well. Then let's look at this one. So over here we see a slight Q wave over here, lead to not much. AVR we ignore it, and then in AVL we see something as well. So that tells us that this is affecting the lateral region, and it is also accompanied by some ST elevations, but they're not very severe, but you could still say it's about acute subacute. Then let's look at our last one. Over here, we see pretty prominent Q waves in V1, V2, V3, and in V4 as well. So we can say that this is affecting the anteroseptal region, and it is also accompanied by ST elevations. So it is an acute MI. And that's it. Thank you for watching. And if you have any questions, then be sure to reach out to one of the third year education representatives. Thank you.
Hi everyone, I will be explaining the QRS complexes. So for QRS complexes, the first thing you have to check is the normal duration, which is usually up to 0.11. And we usually have, I think the best approach here is to check all of the leads and then find the longest one. If it's 0.12, then you can suspect some ventricular hypertrophy, some myocardial infarction, or some hemiblocks of his bundle. We will go through the blocks, so don't worry. And if it's greater than or equal to 0.13, then it can be a his bundle block, which can be either a left bundle branch block or a right bundle branch block. So I think the best thing we can do now is to look at the blocks. And as you can see here, we have right bundle branch block and left bundle branch block. The right bundle branch block, usually we say William Marrow. So Marrow, M in the V1, W in the V6. Right bundle branch block, it produces an RSR pattern in V1 and a deep slurred S wave in the lateral leads, which are V5 and V6. So this is what you should look for if you're suspecting right bundle branch block. So first of all, you have to check if the duration is longer than or equal to 0.13, and then check for this pattern. It doesn't, when I say marrow, it doesn't have to look like a W. You just have to see like a deep S wave, which is abnormal usually in the lateral leads. Left bundle branch block, usually we say William. So you see the deep S waves in V1 and the notched R waves and absent Q waves in the lateral leads. So again, bundle branch block, look for when you see a long QRS complex longer than 13, suspect the bundle branch block and then look if it's like William or Marrow. Uh, if you see a bundle branch block, but the duration of the QRS is not that prolonged, it's usually like 0.12, then suspect a hemi block. For example, you see the right bundle branch block pattern. So, and you see that the QRS complex is 0.12, then you say incomplete right bundle branch block. If it's more than 0.12, like 0.13, then it's already complete bundle branch block. For the left bundle branch block, it's divided, the hemi blocks are divided into two parts, which are the left anterior and left posterior fascicular block. So for the left anterior fascicular block, you should usually see a left axis deviation. And I think Fatima will explain the axis deviation, but quickly, left axis deviation means that lead 1, the overall deviation is positive, and lead 2, the overall deviation is negative. You also see QR complex in lead 1 and AVL, and RS complexes in lead 2, 3, and AVF. Now, this is hard to remember, but I think if you know this, it will be much easier to spot than just relying on left axis deviation. So if you see left axis deviation and you see the QRS, sometimes the QRS complex is normal or slightly prolonged, like 0.12, then suspect the left anterior fascicular block or hemi block. For example, here you can see that the lead 1 is positive and lead 2 is negative. This is left axis deviation. And we said QR complexes in lead 1 and AVL. You can see Q and R. And RS complexes in lead 2 and AV2, 3, and AVF, which are the inferior leads. So these ones. Left posterior fascicular block is the opposite of left anterior fascicular block. So you see right axis deviation, which is usually, if you see lead 1 negative, then you can already suspect right axis deviation. Right axis deviation can be caused by other stuff too, but if you suspect the hemi block because the QRS is already prolonged, not like a hypertrophy, then it's a left posterior fascicular block. And instead of QR in lead 1 and AVL, you see RS in lead 1 and AVL and QR in lead 2, 3, and AVF. I like to remember it because, it's QRS. So in anterior block, QR is in lead 1. Like QRS, like it's beginning in lead 1. And RS is in lead 2, 3, and AVF. I know you don't have to remember the QR and RS, but it will help you a lot in internal. You don't have to remember it, I think, for pathophysiology, but if you know it from now, it will help you so much when you start internal medicine 1. And then the next thing that you need to know for the QRS is the Sokolov's index, which is for right ventricle, you calculate the amplitude of R in V1 and S in V6. And if it's less than 1.05, then it's normal. If it's larger, then it's hypertrophy. And for the left ventricle, S in V1, R in V6, or S in V1 and R in V5. And should be less than 4 millivolt or 3.5 millivolt respectively. And if it's larger, then it's hypertrophy. One thing about Sokolov's index is that you cannot calculate it in left and right bundle branch block. So if you see the QRS prolonged, you should not calculate it because it's irrelevant. Maybe the axis deviation or the very abnormal shape of the QRS in the pericardial leads is not from the hypertrophy, but from the left bundle branch block or the right bundle branch block. So Sokolov's index, if you see a normal duration of QRS complex or 0.12, calculate Sokolov's index. Even if you're not sure, you're like, it's 0.12, I'm not sure if 0.12, calculate it. I think it's better. But if you see it prolonged, like you're sure it's like 0.16, then don't calculate it. So before we go on to the next slide, maybe think about the reasons of left ventricular hypertrophy. I know this is not part of the ECG test, but sometimes, if you go to Professor Kuba, he likes to ask such questions. So 10 seconds just to think about what could be the reason of left ventricular hypertrophy. And the reasons are, as you can see, the most common cause of left ventricular hypertrophy is hypertension. And then, ones like aortic stenosis, aortic regurgitation, mitral regurgitation, coarctation of the aorta, hypertrophic cardiomyopathies. These are all reasons for left ventricular hypertrophy. I think the main ones you should know, at least even now for pathophysio, is hypertension and aortic stenosis. These are some additional ECG changes that you can see in left ventricular hypertrophy. You don't need to see it, like it's not like necessary to be there, but if it's there, then you can be more sure that it's left ventricular hypertrophy. You can see left atrial enlargement, so the mitral shape, so like prolonged interval of the Q wave, of the P wave, and left axis deviation, which again, as we said, lead one would be positive and lead two would be negative. So as you can see here, the left ventricular hypertrophy. One way which is easy to remember, because sometimes the waves like overlap and you're not sure where it begins and ends. So you need to calculate Sokolov's index regardless, but you can see that, it's obviously very long and they're overlapping. So you can be sure, okay, when you see overlapping QRS complexes in the pericardial leads, you can be sure, okay, this is a left ventricular hypertrophy, or not right, but left ventricular hypertrophy. And okay, so this is left ventricular hypertrophy. So now right ventricular hypertrophy, 10 seconds just to think about the causes. So the causes of right ventricular hypertrophy, as you can see, we have pulmonary hypertension, mitral stenosis, pulmonary embolism, chronic lung disease, congenital heart diseases like tetralogy of Fallot, and the pulmonary stenosis, arrhythmogenic right ventricular cardiomyopathies. These are some like causes of right ventricular hypertrophy. I think it's important to remember for pathophysiology, I think it's there in the CVS chapter, and I think it's also important for internal medicine one. So it's just good to know like what causes right ventricular hypertrophy. And as you can see here, this is right ventricular hypertrophy. I don't know if we can see other signs. Maybe there is like right atrial enlargement. You can see the P waves are slightly longer, slightly taller in height amplitude. So you can say that maybe there's right atrial enlargement. And as you can see here, we said that R in V1, it's obviously very, very long. And there's deep S waves in V6. So I think it's most definitely more than 1.05 millivolts, and so then you can say it's right ventricular hypertrophy. So if you wanted to determine if there's like left or right ventricular hypertrophy, first of all, check the duration. Is it normal duration or like slightly like 0.12? Then you can say, okay, now I can calculate Sokolov's index, and now I can say if it's right or left ventricular hypertrophy. But if you see the QRS complex is prolonged, like very prolonged, 0.13, then forget about if it's hypertrophy or not. Don't calculate Sokolov's index. Usually it will be a left or right bundle branch box, so look for those. There's another pattern that there's another pattern that for some reason it's there in the pathology PPT, so I'll explain it now. I don't know if it's not, I don't think there's any ECG in your booklet that has this pattern, but it's quite important for internal medicine one, so I think it's important to know, which is Wolff Parkinson White, which is a type of supraventricular arrhythmia, which we call AVRT. And the way you recognize Wolff Parkinson White is that the PR interval, or the PQ interval, as we say here, less than 0.12. So it's like shortened. There's something we call the delta wave, which is like the slurring part here. It's the slurring slow rise initial portion of the QRS. And the QRS is prolonged, usually more than 0.11 seconds. And so now we can deduce that it's a type of supraventricular arrhythmia, usually AVR, Wolff Parkinson White and AVRT. And Wolff Parkinson White is the type of like pre-excitation syndrome. We call it pre-excitation syndrome. Again, I don't think you need to know this now for pathophysiology, but if you like start learning from now for internal medicine one, it will make ECG so much easier. And okay, so you can test yourself on this. I'll I'll give you like 2 minutes. I think this is not I don't want you to do the entire ECG. Just think about, okay, what is wrong with the QRS complexes here? So, first of all, you can clearly see that the QRS complexes is prolonged, and clearly it's more than 0.13 seconds. I can not clearly see how much is it, but it's probably like maybe 0.20 or something like that. Yeah, I think it's 0.20 or 0.24. So it's definitely prolonged more than 0.13. And if it's prolonged, we don't calculate Sokolov index. So you don't have to check if there's left or right axis deviation, not like even the V1 RV1 SV6, this thing, you don't have to check for it. So QRS prolonged more than 0.13, so we suspect the bundle branch block. And if you see here, you can see that there are deep S waves in V1. They're not really notched, but it's a bit notched in V6 and V5 if you see, notched R wave. So deep S waves in V1, notched R wave in V6. So we say William. So this is a left bundle branch block. Yeah. It doesn't have, when we say William, again, I'm just emphasizing this uh, idea that when we say William, it doesn't have to look like a W for you to be like, okay, if it's not a W, then it's not a left bundle branch block. No, that's not true. You just have to see deep S waves in V1. And you have to see slurred R waves or some sort of like notched R waves or something like that for it to be left bundle branch block. So you see deep S waves, notched R waves. So this is a left bundle branch block. And I can give you again 2 minutes for this one to see which type of block is this. So if you guys look at the ECG, you can see that the QRS complexes are quite normal. They're less than 0.11 seconds basically, and so you can calculate Sokolov's index normally. I don't think it's that prolonged. I don't think so. Could be. I'm not sure, but if you check here, you can see that there's a left axis deviation. Lead 1 is positive and lead 2 is negative, so this is left axis deviation. And do you remember when we said, okay, QR in lead 1 and AVL and RS in lead 2, 3 and AVF? So in lead 1, you can obviously see the QR, even lead AVL, QR. And in lead 2, you can see RS, RS, even in AVF, RS. So this ECG is actually a left anterior hemiblock. For left anterior hemiblock and left posterior hemiblock, it doesn't have to be, the QRS doesn't have to be that prolonged. It can be even normal. But when you see left axis deviation and you see this weird pattern of like QR and RS, then suspect a hemiblock. And if it's 0.12, also suspect usually very high suspicion of hemiblocks. These left anterior and left posterior hemiblocks are part of the left bundle branch block, but when both of them exist together, we say it's a left bundle branch block, like a complete left bundle branch block. Incomplete right bundle branch block will have the same pattern as the right bundle branch block. So you see the um, like the RSR pattern in V1, and you see the deep slurred S waves in V6, but the QRS complexes will not be prolonged, will not be 0.13, it will be 0.12. So I just wanted to point out the difference because I know there are some ECGs in the booklet that have incomplete right bundle branch block, and I think it's important to know the difference between a complete and an incomplete right bundle branch block. Incomplete right bundle branch block, again, is just a hemiblock, which is not prolonged. The QRS is not prolonged. So yeah, so this is left anterior fascicular block.
Okay, hi everyone. Welcome to the next part of the ECG seminar. I'm going to cover the ST segment and onwards. So I'm going to talk about the main electrical axis first. I know it's the last step, but it's important because I need you guys to get an idea of what part of the heart is affected in case there is any pathology. So the main idea you need to understand is that mean electrical axis will tell you the overall electrical activity of the heart. What direction does it point to? And in case there's any pathology where there's a reduced conduction in some area, there will obviously be a reduced electrical activity in that particular area. So the mean electrical axis is going to be deviated to somewhere else. So when you calculate the mean electrical axis, which you do by the Einthoven triangle, which I'm sure everyone's familiar with, so I'm not going to go into detail. You need to mention what the angle is, of course, and then you also have to mention whether the angle is like positive or negative. Like there's no point just putting 30, you have to mention that it's plus 30. And then you have to mention what axis it is. So even if it's in the normal axis range, which is minus 30 to positive 110, you have to mention that it is normal axis. And in case it's a pathology, for example, it's minus 60, that's obviously a left axis deviation. Definitely mention minus 60 and left axis deviation and underline it as well, because of course you need to underline your pathologies. Now for the tips for mean electrical axis, what you should definitely do is write out your QRS values for lead 1, 2, 3, and then take the sum of the QRS, for example, for lead 1, and then use that value in your Einthoven triangle calculation. And you should try and do this if you have the time for 2 moments in time. So what I'm saying is do one triangle for, let's say, the first QRS complex in lead 1, 2, 3, and then if you have the time, do another Einthoven triangle, but for another set, like for example, the second set of QRS complex in lead 1, 2, and 3. So for example, if I'm doing an mean electrical axis of this ECG over here, which is just a sample, I will take the values of QRS from this moment here and here, because all of this is happening at the same moment in time. Don't take it from like lead 1 over here, but lead 2 over here and lead 3 over here. Your values are not going to match up. And if you have the time, go for like a second round with different values from the ECG. And then if you can, use an ECG ruler. If you don't have this, maybe you can stop by the biophysics department and they will give them to you. As for, yeah, I mentioned 2 triangles with different values. And the reason why I started off with the mean electrical axis is because I wanted to emphasize what leads represent what area of the heart. So this diagram over here can show you that, for example, if the AVL is, I mean, it was present over here, When it looks at the heart, you're looking at this particular area of the heart. That's part of the lateral area. And notice also that V5 and V6 are also, sorry, V5, V6 here are also pointing towards that area. And if you've heard it so many times, you would also know that 2, 3 AVF are the ones which look at the inferior part of the heart. And that makes sense because when you look at this diagram, 2 is looking at this part of the heart, AVF is looking at this part, and 3 is looking at this part. So this diagram is pretty useful to help you understand why some of these areas look at these specific parts of the heart. So you need to know for sure that, for example, 1 AVL, any pathologies in these areas are referring to the lateral aspect of the heart, and that if you have 2, 3 AVF, it's referring to the diaphragmatic part of the heart, V1, V2 septal, and then V3, V4 anterior, V5, V6 lateral, so on and so forth. So two main things is the meningeal axis. You need to calculate with the Einthoven's triangle, mention the positive or negative for the angle, and the axis. And the other thing is knowing all of this. Absolutely have to know that. As I've mentioned, you can calculate the the mean electrical axis with the Einthoven's triangle, and there are some neat tricks to help yourself confirm whether you have the correct mean electrical axis or not. So this diagram over here helps explain this table over here. And one of the quickest way to confirm your mean electrical axis is by looking at lead 1 and AVF. So let's say over here, lead 1 generally is positive, and lead AVF over here is also generally positive. Now, if I'm looking at this diagram here, here is where lead 1 goes. That means this side of the vectors or whatever, here is where lead 1 is positive. And if I look at AVF, where it's negative, 0, positive, this side of the graph is positive for AVF. So since both my lead 1 is positive, that means somewhere here, and my AVF is also positive, which means somewhere here, the overlapping area is somewhere in this quadrant. So that's what's mentioned over here. If lead 1 is generally positive and AVF is generally positive, then the mean electrical axis is going to lie somewhere here in the first quadrant. So in the same way, let's say lead 1 is positive. That means somewhere here on the graph. But lead AVF is negative. That means somewhere here on the graph, the overlapping area is this quadrant. Or in this image, it's quadrant number 3. And the other quick trick to help yourself confirm the mean electrical axis is to generally look at which is the most positive lead. So in this case, it like from all of these, usually you look between 1 all the way to AVF, but most importantly, I'd say is 1, 2, and 3. It looks like lead 2 seems to be the most positive. So you would imagine that the mean electrical axis lies somewhere near lead 2. And this is not your definitive value. Your definitive value will come from the Einthoven's triangle. You can just use these methods to help confirm where exactly your degree lies. So in this case, what I mentioned was that it's definitely going to be somewhere in quadrant number 1, somewhere over here, because both lead 1 and AVF are positive, and it looks like lead 2 is the highest, so some of QRS. So that's why I'd say it would be somewhere around here. So I'm thinking like positive 30, 40, 45, like that. And if my Einthoven's triangle calculation is like, then I can rest assured. So that's exactly what's mentioned over here. Now for the ST segment. So you should definitely know all these tolerances, which I've mentioned over here. Generally, for these apply for elevation, that it can go maximum to this much. And if you have an elevation that is higher than this, it's 100% of pathology. You have to underline it and you have to somehow mention it in your conclusion. Like, what exactly is this elevation for? Um, Usually for this ECG test, your elevation is limited to a STEMI or a myocardial infarction, and other pathologies related to ST elevation is pericarditis, but fortunately, there are no questions related to pericarditis. If you're curious, pericarditis looks like a diffused ascending elevations. That means in multiple leads, you have like the elevation that goes kind of up like this. And there is a PR segment depression, but you don't have to worry about it because it's not on the test. Now, for the other thing I wanted to mention is that there is no tolerance whatsoever for depression. Um, so if you see the slightest bit of depression, underlying there's a pathology, and the reason why is going to be because of it's mentioned in the books depolarization disorder, but what the pathophys department prefers hearing is ischemia. So definitely mention that. And of course, underline your pathology, you have to mention the area affected. So let's say that I am looking at my graphs, my ECGs, and I notice that there are ST elevations, which are definitely pathological, and they are located in V1, V2. So what part of the heart is affected? It should be the septal region. So you would have to mention, like let's say it's a Parties waves, which I'll explain, which is an acute MI. You would mention in the conclusion myocardial infarction, acute because it's Parties waves, and that it is septal MI. Okay. Um, Now, how exactly do we determine the ST segment? Personally, it was probably the most time consuming and difficult part. But what you need to be able to identify is this J point. If you identify the J point, everything is going to be easy for you. So what you need to do is compare the J point to the isoelectric line. So the J point is basically the point from which the QRS complex ends, and it's basically the start of the ST segment. So you have Q, R, S, that's the end over there. This is my ST segment, and this is my T wave. So same thing over here. This is the J point, this is the J point, here it is, here it is, here it is. And you would want to compare this J point to the isoelectric line. The isoelectric line is basically like the baseline of the ECG, and make sure that you're comparing the J point to the isoelectric line that's right behind it. Don't go to like two QRS complexes behind, because it's possible that the leads can be pushed around. So sometimes the entire thing is not isoelectric. Some areas might be higher than other areas. So stick to the same like moment in time. So over here, you can see that clearly this is isoelectric, that's okay. Here there's an elevation, here there's an elevation, here there's a depression, and here there's an elevation. So this is basically what I emphasized. Here you have the ST segment. Around here would be the J point, and it seems to be isoelectric. Here, obviously, it's elevated, and here it's depressed. But again, if there are elevations, be careful to look on whether or not it is pathological. In case it is within this limit, you have to mention still that there is an elevation, just don't underline it. You only underline it if it is above this tolerance. And again, for depressions, there are no tolerances. I think that is about it. Oh yeah, I had to mention for the elevations that they will be STEMI, which is an ST elevation myocardial infarction, and you have to mention what stage, which I will explain in the next slide. And then there's a special mention of Parties waves. You also have to mention what area is affected. And there's one pro tip that if you spot an elevation related to a myocardial infarction anywhere, you can have a depression in the opposite leads. So if you have a STEMI in one AVL V1 to V6, that's like the anterolateral part of the heart, you will see depressions in 2-3 AVS, which is the inferior part of the heart, which is kind of opposite. But it's not necessary to identify, and it's just like something to help you in your conclusion, something good to know. So here we have the Parties waves, and the Parties waves are called parallel elevation of ST segment, which you can see over here. But I feel like a better explanation of the actual image would be that there's a parallel ST elevation, which you can see here with the J point being high up from the isoelectric line, and it is combined with a T wave. So this would be the T wave over here. In this case, the T wave is positive. It will always have to be positive in a Pardy's waves, or it could be like pre-terminal positive biphasic, something like that. But the point is that the T wave is sort of combined with the ST elevation. So for example, over here, you have a QRS. This is your J point, which is elevated for sure, but you can see that the T wave is negative at this point. This is not a Pardy's wave. So Pardy's waves have very characteristic appearance, which is quote unquote parallel elevation of ST segment. You can see them over here, 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 but not in V1. So in this case, the conclusion would be, well, because it's Pardy's waves, you'd know that it is an acute MI. So you'd have to mention acute MI, and then you have to mention the area. It's all the way from V2 to V6. So that's like enterolateral, which is what I've mentioned over here. You also need to know how the MI changes over time so that you can identify it appropriately in the ECG. And you have to mention that whether it is acute, subacute, or chronic. The chronic MI is also like the scar after MI, but you can use either of the terms. So for the acute MI, the key sign is the Pardy's waves, which we can see very nicely over here. And then we have the subacute, where the Pardy's wave or the ST elevation decreases slightly, which you can see with this arrow over here. And you start having a negative T wave, which you see here. And you have a prolonged Q, which you see over here. And in a chronic, it is only prolonged Q. So from acute, it starts as Pardy's waves, which is here. And then the Pardy's wave slightly decreases, but you start having a negative T wave and a prolonged Q. And then finally, in a chronic MI, you have a prolonged Q. And notice over here how I've mentioned that it has to be in more than one lead. That's because sometimes you might have a prolonged Q, but only in a single lead. In that case, in your conclusion, you have to just mention prolonged Q in this lead. But if the prolonged Q is in an area which makes sense, like for example, 2,3 AVF, then you can consider it being a chronic MI in the diaphragmatic part, because it doesn't make sense for a prolonged Q to only be in lead number 2 and not 3 in AVF. So in case you only see a prolonged Q in number 2, then you just mention in the conclusion prolonged Q in lead 2. But if you see it in 2,3 AVF, then it's going to be a chronic MI or a scar after MI in the diaphragmatic part of the heart. So always make sense of like where you're seeing the pathologies. Now we have the T waves. They are pretty easy to identify. Here is what it should normally be like. Lead 1 and 2, positive concordant. What does that mean? Well, T wave has to be positive, and concordance refers to whether it is like on the same side as the biggest part of the QRS complex. So in this case over here, the biggest part is the R wave, and obviously T over here is positive, and it happens to be positive here and also for the QRS complex, so that's why it is concordant. Over here, for example, the T wave is negative, but over here the QRS complex or the R wave, the biggest part of it, is positive. And in this case, it's disconcordant because they're not matching. They're not the same like polarity. In this case over here, the S wave is, or the QS, is pretty big and it's negative. Over here, the T wave is positive, but it's not on the same polarity. So that's why you're just going to say it's positive and disconcordant. Over here, the T wave is negative, and the biggest part of this QRS is going to be, it's probably R and S. So this is also negative. That's why they're concordant, and this of course is negative. So negative concordant. Now these are what it should normally be like, and anything apart from this is a pathology, and that also includes biphasic waves. So biphasic waves look like they have like two waves like this. There's pre-terminal negative biphasic and pre-terminal positive biphasic. So pre-terminal literally refers to the very first wave and whether it is negative or positive. In this case, the very first wave is negative, so that's a pre-terminal negative biphasic. And in this case, the very first wave is positive, so it's a pre-terminal positive biphasic. Of course, since it's a pathology, you have to underline it. And the reason for this pathology is ventricular repolarization disorder. You do not have to mention more than that. And another thing is that if you have a negative or pre-terminal negative T wave, I recommend you look for a possible subacute MI. Why is that? Because when we talked about subacute MI, we talked about a Pardes waves or an ST elevation, which is slightly lower than you expect, a negative T, and a prolonged Q. So if you see a negative T anywhere, keep an eye out for a subacute MI. Now, here's practice question. Is question number 13 from the ECG booklet, and I recommend focusing on T waves. So just pause for a minute and give it a try. Okay, so now when you're doing the T waves from all of this, you can sort of see here that generally maybe the T wave is positive. Here, it is pretty obvious that it is positive. Here, sort of as well. Here, yeah, probably. But now it's looking a little bit weird here. That's because over here it's starting to look biphasic. And how can you truly identify if it's just a positive or a biphasic? Look at the ones in the other lead at the same moment in time. So you can see here in lead 2 that this is very obviously the peak of the T wave. And when you go down at the same exact moment in time, you can see that the line is passing through this area. That means this is a biphasic wave. You can see that over here it's positive and it's negative. So you'd consider this a pre-terminal positive biphasic wave. So same thing applies over here. Very obvious that this is a T wave. And when you're going down here, you realize that you're going right through the middle. That means all of this here is biphasic waves. This is probably just positive, positive. So that was the answer over here. And of course, the biphasics are pathological, so you underline it. And you mentioned repolarization disorder in your conclusion. Now, QT interval is pretty simple. You just need to know that it needs to be this much in normal heart rate. Just something additional to know is that if you have pathological heart rate like tachycardia or bradycardia, you have to correct it with a special formula, which you don't need to know. And the pro tip is that if you want to check real quick, if your QT interval is normal or pathological, in normal cases, it needs to be less than half of RR interval. So here's another practice question. It's question number 12. I want you to focus on Q duration, ST segments, and T wave. Okay, so over here, you can see. So I hope you realize that the Q waves in number 3 were a little bit prolonged. Let me see, it's not very obvious here, but you can see that possibly here, definitely here, maybe here, not so clear here, but it is visible here, here, and here again. Personally, if you see more than 2 areas which has a concern, you can consider that lead to be pathological or affected. So over here for lead 3, it's about one small box wide, and that's pathological. So over here it's underlined as like prolonged. And the same thing goes for V1, where this is the QS complex. You take the entire width, and in that case it's 0.1. Then go on to the ST segments, where you can see that there is very clear depressions in the lead 1, and then in lead 2 in some areas, for example here, there are very obvious depressions. And AVR is an elevation very slightly, but it looks like it's pathological. And then you have depression in AVL, and then V3 all the way to V6 is very obviously depressions. And then the T waves in this is normal, QT interval, you can do it easily, mean electrical axis, you can do it easily. Now, what was my main reason of using this ECG is that now that you know that there is a Q, prolonged Q in lead 3 and V1, well, what could it be? Well, we know if it's just a prolonged Q, not a Pardy's wave, no weird T waves, then you can consider it to be a chronic MI, which is what we've written over here. And we have also mentioned the area. And the question is, what area is it? Well, if it's V1, it could be septal. If it's V2, it's septal. If it's 3 on its own, it's a little weird because normally if lead 3 is affected, you would expect lead 2 and AVF to also be affected in case that it is the inferior aspect that is affected. But in this case, lead 2 and AVF are normal, which is why we're only mentioning that the MI is enteroseptal or septal. It is chronic because only Q wave is prolonged. And we have mentioned also that Q wave is prolonged in lead 3 or pathological in lead 3. And of course, because we have depressions, we have to mention that there is repolarization disorder. Here's the next question. So over here, you can see that the Q wave was prolonged in 3, very obviously, because this is the QS complex. And then in other areas, you also have a Q wave, but they're not pathological. Then in the ST segments, we can see that in this one is pretty much isoelectric. Here there is a depression. As I mentioned, there is no tolerance for depression. So that's a repolarization disorder. And then we have isoelectric and all the way until V3 again, where we have depressions. And then V4, V5, and V6. Very slight depression, but evident depressions. In this case over here, we can also see that the T wave is pathological in some areas. For example, in number 2, it is negative and it is discordant, but it should be positive and concordant. And then in AVR over here, we have a biphasic pre-terminal negative because you can see that it's like a double wave and the first wave is more negative. And how can you confirm? If you go along that moment in time, you realize that you're going in the middle of the biphasic wave rather than a particular peak. So based off of all of the data that we have to make a conclusion. So we can see that we have a prolonged Q in number 3. We can see that we have depressions from V3 all the way to V6, and then we have some negative T waves or pre-terminal negative biphasic T wave. So if you have a prolonged Q, you have some irregularities with the T wave that should be subacute. As we go back here, subacute would either be a decreasing Pardy's waves, but definitely a negative T and possibly a prolonged Q as it transitions to chronic MI. So that was the conclusion over here. Based off of all the data highlighted in yellow, you can say that it's an MI, and the reason why we're saying diaphragmatic is because you can see that although Q was only affected in 3, you have 2 and AVR for where T is affected. So it's 2-3 AVF, that means it's the diaphragmatic areas. And of course, you have depolarization disorders with the depressions. Again, I mentioned why not prolonged Q in 3 mentioned in the pathology. That's because you can see that prolonged Q is actually linked with the depolarization disorder in excuse me, you can see that it's linked to the T waves in 2 and AVR. Okay, that is the end of my presentation. I hope it helped. If you have any questions, please feel free to reach out to me and I will be happy to help. Thank you for your attention. Have a nice day.
Oh, we can start, I think. Okay. If you need more time, it's a recording. You can always pause the video. Okay, we can go through the 10 steps quickly. So for the rhythm, the heart rhythm, you can clearly see it's irregular. The distances between the QRS complexes are not regular whatsoever. You can see here the difference. So first of all, rhythm, irregular. Second of all, action is irregular. Rhythm, here, you don't see clear P waves before each QRS complexes in lead 1 and lead 2. So it's non-sinus rhythm. We'll go figure out what is it later. And the frequency, I don't know if you can calculate it, but like, okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So 17 times 6, that should be so it's 102. For those who don't know, the rhythm strip in front of you is 10 seconds. So you calculate the number of QRS complexes in the rhythm strip and multiply it by 6, and that should give you the frequency, the heart rate or the frequency. For the P waves, you clearly don't see P waves. So you suspect some kind of P wave pathology, which could be atrial fibrillation or atrial flutter. You'll learn that there are many more, but for now, in the booklet, there are these two ones, atrial fibrillation and atrial flutter. If you're not here, you can see some P waves, and you can calculate the distance between them and find the frequency of the P waves. One thing that always helps to know is that atrial fibrillation will always present with irregular action. So if you see the QRS, first of all, you don't see P waves. You suspect a non-sinus rhythm. It's high heart rate, like tachycardia. And you see that the action is irregular, suspect atrial fibrillation. Usually atrial flutter will always be regular. Okay, there are some exceptions, but in your booklet, it will always be regular. The action is regular. However, for example, for atrial fibrillation, if you see irregular QRS complexes, the action is irregular. Usually, 90% of the time, it's atrial fibrillation. And you can use this also for internal medicine, because sometimes the P waves are not even visible. You can't even tell if there's flutter or fibrillation. There's no P waves. There's nothing preceding the QRS, but you can see that the QRS action is very irregular. You say atrial fibrillation immediately. Sometimes that's the only way in internal medicine that we figure out that something is atrial fibrillation. We look at the action, we see it's irregular, we say it's atrial fibrillation. So PQ should not be calculated when you see atrial fibrillation or atrial flutter. QRS complexes are narrow. Here, I think they're like 0.10. If anyone wants to solve this ECG, it's ECG number 27. I should have mentioned that in the beginning. I'm so sorry, but this is ECG number 27. And if you see the Q waves in the QRS complexes, you can clearly see Q waves in lead 3. They are pathological Q waves in lead 3 and lead AVF. I think also you can see it in lead V1, V2, V3, V4. Yeah. So you see Q waves in lead 3 and AVF. Q waves are usually a sign of previous myocardial infarction, so a scar. So in the ECG booklet, they usually mention the Q waves as chronic myocardial infarction, or you can just say previous myocardial infarction or scar. But they usually mention chronic myocardial infarction, and the position of lead 3 and AVF is diaphragmatic or inferior. I think you guys know the divisions of the leads. Lead 1, AVL, V5, and V6 are the lateral leads. Lead 2, 3, AVF are the inferior leads or the diaphragmatic leads. And lead V1 and V2 are septal leads. And V3, V4, like V2, V3, V4 are anterior leads. So we see the Q waves, the pathological Q waves in lead 3 and AVF. So we suspect the scar in the diaphragmatic surface. So chronic myocardial infarction, which is not a real term, but that's how they write it in the ECG booklet. Chronic myocardial infarction in the diaphragmatic leads, so diaphragmatic myocardial infarction, chronic. And we see it also in lead V1, V2, V3, and V4. And as we mentioned before, lead 1 and V1 and V2 are the septal leads, and V2, V3, and V4 are the anterior leads. So it's chronic myocardial infarction in the anterior septal leads. So far we discovered two pathologies, which is atrial fibrillation and myocardial and a scar after myocardial infarction in the anterior septal and the diaphragmatic leads. One other thing that you have to note is that we can do ST. The ST segments are all isoelectric. There's no pathology in them. T waves are usually here are hard to differentiate from the P waves, so you can actually say for some of them, at least, that you cannot differentiate. But there's also no pathologies here in T waves. The QT interval is also normal. It's 0.32 seconds, but the axis. Also, Sokolov's index is quite normal, so there's no hypertrophy. The axis here, if you see lead 1, it's positive. It's like a positive deviation, and lead 2 is negative. Also, AVF is negative. So in this case, you suspect left axis deviation. Actually, the axis here is negative 40. So this is definitely left axis deviation. Okay, one thing you need to know. Okay, so you checked the Sokolov's index. There is no hypertrophy. The QRS complex duration is normal. The only thing you see here is that the there's left axis deviation not explained. If there's left axis deviation that is not explained, usually it means most of the time left anterior hemiblock. So left axis that is not explained by anything. There's no hypertrophy. There's nothing that can explain it. Not even like prolonged QRS complexes, which can be with left bundle branch block. Normal duration of QRS, normal Sokolov's index, then you can suspect left anterior hemiblock. I don't know if you can see, there's not like, it's not there's no QR in lead 1 or AVL, but you can see some RS in lead 2. Again, see, that's not, the QR and RS are not always there, but the one thing that has to be there for left anterior hemiblock is the left axis deviation. So yeah, so pathologies in this ECG are atrial fibrillation, which we discovered because the action is irregular. The myocardial infarction, the chronic myocardial infarction with the scar, because there are very prolonged QRS, Q waves in lead 3, AVF, V1, V2, V3, and V4. And last one is left anterior hemiblock, which presents as left axis deviation that is not explained by anything. So this is the first ECG, and we have the second ECG. You can pause the video if you. For anyone that wants to solve this ECG, it's ECG number 29. Okay, so again, we will start the 10 steps quickly. So, action. As you can clearly see, very irregular. As you can see, there's no regularity, maybe a bit here, but then again, it starts to become irregular. So action is irregular. Rhythm, well, as you see in lead 1 and lead 2, there's no P waves preceding each like QRS complexes. So again, we can say non-sinus rhythm. Okay, so we already know that the action is irregular. We already know that it's non-sinus. So, and actually the frequency here is not so high. We can get 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 11. So 11 times 6, 66. The heart rate here is 66. So it's low. You don't really expect that with atrial fibrillation, but there might be another reason why the frequency is low. So, okay, we already know that the action is irregular. It's not sinus rhythm. Frequency is too low, maybe for atrial fibrillation, but as you can see, there's no P waves, regular P waves. So you immediately suspect atrial fibrillation. Action is irregular atrial fibrillation. And it's actually atrial fibrillation, and I don't know if we see any P waves that we can calculate, maybe here. And the frequency of the P waves is 500 per minute, 500 beats per minute. So it's quite fast actually. So there might be something else that is decreasing the heart rate, because when we think of atrial fibrillation, we usually associate it with tachycardia. But if there's low heart, it's not low, it's normal, but it's low for an atrial fibrillation. We suspect some kind of block. Keep in mind any block, maybe not really AV block because we cannot calculate the PQ interval, but it could be a branch block. Okay, so now the QRS. The QRS, as you can see, is very prolonged. It's actually 0.15 seconds, so we cannot calculate Sokolov's index here. The Q waves, nothing. There's no weirdly shaped Q wave, so we'll skip that. And ST segment, I think there's depression in some of them, maybe here, but who knows? It's can this usually when you see ST segment changes and T changes that are not like with the specific pattern, you usually say there's just a disorder of repolarization. So there are some changes with ST, even T waves. You can see like some biphasic T waves, I think here, quite biphasic, even here. Some discordant ones, I think in lead 2, it's discordant, even in lead 3, discordant. So these ST segment changes, ST and T wave changes, we just say disorder of repolarization. The QT interval normal, it's 0.40. You can calculate this, for example, 0.40. And now the heart axis. You can see lead 1 is positive, lead 2 is negative, so there's some left axis deviation. So left axis deviation, but here the QRS is prolonged, is 0.15 seconds, so we suspect some type of bundle branch block. And if you see lead 1, so first of all, there's left axis deviation, which can only be left axis deviation, but you cannot calculate if there's hypertrophy. There's nothing else that explains it, so it's actually left anterior hemiblock. So there's left anterior hemiblock in this ECG, and the prolonged QRS can be explained. I don't know if you can see it well, but there's maybe in V2, like check V1 and V2 for both. You can see some RSR pattern in V1 or and V2 mainly. And in V6, you can see the deep slurred S wave. So RSR pattern in V1/V2 and deep S waves in V6. So that should mean that it's a right bundle branch block. Right bundle branch block, the conditions, prolonged QRS complex, here it's 0.15, like anything above 0.13 or equal to 0.13. You see some RSR pattern in V1 or V2, and you see deep slurred S wave in V5, V6. So this is right bundle branch block. We also have left axis deviation, which cannot be explained by anything. You cannot see hypertrophy because it's QRS is prolonged. We cannot calculate it. So there's also left anterior hemiblock. And usually when we have a right bundle branch block and a left anterior hemiblock, We call it a bifascicular block. So the pathologies in this ECG is atrial fibrillation, which is explained by the irregular action. Second thing, we have the bifascicular block, the right bundle branch block, and the left axis deviation. And the ST changes and the T wave changes explain we can be summarized in the pathology as disorders of repolarization. And yeah, I think that's it for this part. Uh, yeah, and the first ECG was ECG number 27, and this was 29. And good luck. I think if you guys have any questions, you can send it us on WhatsApp, and we'll be more than happy to help.